Get started. Hi, and welcome to the Healthy Living Series presented by Dartmouth Health. I'm Angelica Ladd. I'm Community Relations Specialist here at Dartmouth Health, and we are joined by Dr. Gerard Dillon, cardiologist at the Dartmouth Hitchcock Clinic in Concord. Dr. Dillon will talk about heart health, and he will also answer your questions. But first, we have to do a little bit of housekeeping. So tonight's event is being recorded and will be posted on our Healthy Living Series webpage. And you can find that at go.d-h.org/HLS. And I'll put that link in the chat for you. And it will also be posted on YouTube. So you can watch this presentation again or share it. We try to have it up pretty quickly for you. We also have closed captions available for tonight's presentation. All you have to do is click on the closed caption icon and you'll get live captioning. We have reserved some time, as I said, for questions and answers. So if you would like to ask a question at any time, you can use the Q&A function that we have here on Zoom and submit your questions. At the end of the event, you will be sent a 3-minute survey. If you could please fill that survey out, and it's very quick, I promise. And that just helps us with future programming and also lets us know what you liked and what you didn't like. So please fill that out if you have a chance. So now I am pleased to introduce Gerard Dillon, MD. Dr. Dillon has been a cardiologist with Dartmouth Health since 2000. He practiced interventional cardiology for 15 years, and he currently focuses on general cardiology and preventative care at the Dartmouth Hitchcock Clinic in Concord. Dr. Dillon attended Boston College Medical School at the State University of New York, Buffalo. He did his internship and medical residency at Johns Hopkins Hospital in Baltimore, and cardiology and interventional cardiology at Boston Medical Center in Boston. Dr. Dillon currently lives in Concord with his wife and 2 children. Thank you so much, Dr. Dillon, for being here, and I will give the floor to you.
Thank you very much, Angelica, for that kind introduction, and welcome everyone. Thank you for joining us tonight to speak about the heart, the state of the heart of healthcare, and how we can maintain a healthy heart. I'm going to go through a relatively general overview to start in terms of heart function and problems that affect the heart, and then I'll highlight our treatment of several important heart conditions as examples of how we treat heart disease, and then talk a bit about prevention at the end. Certainly feel free to add your questions, and then I'll try to answer them as best I can at the end. I should say that I'm not I don't have any conflicts of interest. I'm here solely to talk about heart health. I'm not trying to advocate for any specific medication or procedure. I simply want to provide some important information about cardiology, heart health. So let's get started. So we'll start at the beginning with my first slide, but hold on for a second. Angelica, I may need, oh, there we go. Thank you. Our first slide here is just, I'm going to do an overview of heart function, and we'll just get a general idea of the anatomy and function of the heart. As you know, the heart is a pump that pumps the blood. The heart is actually 2 pumps. There's the right ventricle of the heart that pumps the blood to the lungs, and then there's the left side of the heart that pumps the blood to the rest of the body. And going from the upper blue, we see that blood comes back from all the organs in the body after the oxygen is used up. It comes to the right ventricle, which is then pumped out to the lungs, where it picks up oxygen, and then it comes back through the pulmonary veins to the left side of the heart, where it goes into the left ventricle and then is pumped out to the rest of the body. As you can see from the diagram, the heart has valves in it that open and close. These help direct the blood flow in the right direction. Valves will open when blood flow needs to go forward, and then they'll close to keep the blood from going backwards. So that's just a general overview of the anatomy of the heart, which will come up as we continue to talk. The next picture is a picture of the coronary arteries of the heart. The heart does a lot of work and needs a lot of oxygen and fuel to do its work. And the first place the heart pumps blood to is to itself. And the blood supply to the heart muscle comes from the coronary arteries that run on the surface of the heart. And there's two main coronary arteries on the left side of the heart and one on the right side of the heart. And these don't just run on the surface of the heart, but as you can see on the diagram on the right, penetrate into the heart muscle to deliver that blood to the heart. The heart also has its own electrical system that tells the heart when to beat and coordinates the pumping action of the heart. So the heart has its own pacemaker called the sinus node in the upper right-hand corner of the heart that generates a signal to tell the two small chambers of the heart to beat, the right and left atrium. And then the electrical signal is conducted to the rest of the heart to tell that to beat. And when you go to the doctor and they're doing an EKG, we are recording the heart's electrical activity, and we can learn a lot about what's going on with the heart's electrical system and electrical activity through that. So what can go wrong with the heart? I'm going to go over several things that are pretty common. And so one of the most common cardiac conditions is coronary artery disease. And this refers to buildup of cholesterol in those blood vessels that run on the surface of the heart. So when we talk about blockages, we're talking about buildup of cholesterol. So on the left is a normal coronary artery. And what we can see over time is increased thickening of the wall from accumulation of cholesterol. And if you go all the way to the far end of the slide, you can see that enough cholesterol has built up such that there's the channel for the blood to flow is very restricted. So there's blood getting through, but only a limited amount. And that can lead to one of the main manifestations of coronary disease, which is angina. So angina means chest pain due to inadequate blood flow to the heart. So that's one of the manifestations of blockages. The other, of course, is a heart attack, which is where a sudden onset of chest pain, and that's usually due to a blockage in the artery of the heart. So if we go back to this artery, what we can see in the middle part, where we have what's called plaque rupture, where there's cholesterol built up in the artery that becomes unstable. And so it's not initially blocking blood flow, but the plaque becomes unstable and starts triggering a clot. And if a clot forms, as you can see in the second to the right segment here, it actually blocks blood flow to the heart such that some part of the heart muscle is not getting any blood flow. And pretty quickly, the heart starts sustaining damage to the heart muscle. So that's what we would call a heart attack. In layman's term, the medical term is called myocardial infarction, which refers to permanent damage to the heart muscle from a blockage. So on the left of the screen here, we can see a blockage in one of the arteries on the front wall of the heart. And then you can see this zone of purple in the diagram of heart muscle that's not getting adequate blood flow. And then if we cut the cross section of the heart, you can see that some part of the heart is sustained damage. So coronary artery disease, one of the main medical problems that can affect the heart. Other problems of the heart can refer to arrhythmias, which are disturbances in the heart's electrical system. And this can be manifested by the heart going too slow, where for some reason the pacemaker isn't generating a signal to tell the heart to beat fast enough, or the signal isn't getting there. There are other arrhythmias where the heart is too fast, where it's racing all the time, or having episodes where the heart is racing. That can be due to little short circuits in the heart's electrical system. And then there's what's called fibrillation. This is disorganized or chaotic electrical activity in the heart, where that part of the heart is not contracting in an organized fashion. And there's two types of that. There's what's called atrial fibrillation, which can lead to heart racing and blood clots in the heart. And then, of course, there's what's called ventricular fibrillation, which is much more serious, which is when we are talking about a cardiac arrest, is what's going on. And that's where there's disorganized activity in the pumping chamber of the heart, where there's no meaningful pumping action of the heart. Other problems that can affect the heart valve problems. As I mentioned, the valves in the heart open and close to regulate the blood flow in the proper direction. So one problem that patients can get is heart valves not working properly. So for example, and one good example of that is what's called aortic stenosis. Here's the aortic valve that has to open to let blood out of the heart into the aorta, which is the main pipe that delivers it to the rest of the body. And that's the normal valve opening. Some people can develop a condition where the valve doesn't open properly and restricts blood flow. And that can put a strain on the heart and can affect the heart's pumping action. Another problem with heart valve is the valve can leak when it's supposed to stay closed. One example is what's called mitral regurgitation. The mitral valve is the valve that has to open to let the blood into the heart, left side of the heart. And then when the heart contracts to go out the aortic valve, the mitral valve is supposed to stay close and stay closed so the blood doesn't get pumped backwards into the left atrium. And so mitral regurgitation is where a valve is leaking. So there's, and these two problems of regurgitation and stenosis can affect any of the heart valves. And I'm just using those two as a representation. So another common and important problem related to the heart that we treat is what's called heart failure. And that refers to impairment of the pumping action of the heart, where the heart's main job is to pump the blood. And if it can't pump, that causes a lot of problems. So other terms we might use are what's called cardiomyopathy, also referring to impairment of the pumping action of the heart. And there's different types of heart failure. Probably the most common and well described is what's called heart failure with reduced ejection fraction. Ejection fraction is one of the measures we use to say how well the heart is pumping. And if the heart is weak, most often there is a reduced ejection fraction. So, and I'm going to use that as an example. So on the left is a normal heart. And when we talk about heart failure, most often we're talking about heart weakness. Bear with me for 1 second. And on the right side of the screen, we see an enlarged heart that is not able to pump the blood well due to weakness. What causes heart weakness? Multiple things. One of them is coronary artery disease. If you've had damage to the heart from a previous heart attack, there's multiple other things that can cause it, including infection, toxins like alcohol being a common one, heart valve problems, as I've outlined, and then other conditions such as poorly controlled high blood pressure, arrhythmias, sleep apnea is a common cause of heart weakness. And then there's other types such as infiltrative cardiomyopathy, where there's abnormal proteins accumulating in the heart. And idiopathic refers to where we cannot identify a specific reason. And how does heart failure manifest itself? Well, usually by symptoms, most often shortness of breath and weakness. When the heart's not pumping well, the blood tends to back up and fill the lungs with fluid, and people often get swelling in their abdomen or legs as well. And so over time, from progressive weakness, patients can experience disability and death as the heart fails as a pump. Patients with heart failure are also very prone to what is called sudden cardiac death. Patients with weak hearts can get arrhythmias, and that ventricular fibrillation that I was mentioning before is a common problem in patients who have weak hearts. So let's talk about treatment. Treatment falls under several different categories. We have different ways of treating heart problems, and that can include things like medications. There's multiple medications that can help heart problems in various ways, as I'll outline as we go on. Certainly there's surgical treatments and catheter-based treatments. Surgery, for example, coronary artery bypass surgery or heart valve replacement surgery would be a common treatment. Catheter-based therapies include putting stents in blockages, doing ablations for arrhythmias, and treatment of other structural heart disease that can be delivered by a catheter, either through the blood vessel from the wrist or the leg. There's devices that we use to treat heart problems, and this would include a pacemaker for patients who have slow heart rates, and defibrillators for patients with arrhythmias. Of course, in any treatment, lifestyle modification is very important. Weight loss, exercise, and cardiac rehab are all critical parts of treating many heart problems. So as far as specific treatments for specific conditions, I'm going to use a few examples of how things have evolved over the years. And what I'm going to start with is treatment of a very acute and dramatic heart problem, a heart attack or acute myocardial infarction. And just to remind you, this is a blockage in one of the blood vessels of the heart, typically caused by a clot, but usually occurring in a blood vessel that's already has cholesterol buildup, as I showed before. And the treatment has evolved dramatically over the last 70 years. This picture is a picture of the main treatment of heart attacks in the 1950s, and that was predominantly bed rest and prolonged bed rest, which probably actually wasn't very good for people because bed rest can cause a lot of problems, including making patients weaker and blood clots. And I didn't notice this at first when I first added this picture, but the nurse on the right, she's actually helping the patient select some cigarettes that was available in the hospital at the time. Now, in the 1960s, we started having coronary care units, specialized intensive care units to help patients with heart attacks. And as you can see, the cigarette card is gone, and that's now replaced with a defibrillator. Patients who have cardiac arrests are very prone to arrhythmias and ventricular fibrillation, which can cause people to die suddenly. And so our ability to shock patients out of arrhythmias was recognized and developed. And these units were predominantly designed to be able to do that in an expeditious way. A real breakthrough started in the late 70s and early 80s as we realized that heart attacks, the main trigger and problem of a heart attack is clot related. And that's where we realized that treating blood clots with aspirin and blood thinners actually helped patients do better when they were having a heart attack. And this led also to the development of very powerful clot dissolving drugs called thrombolytic drugs. And on the right is an example of a patient getting a thrombolytic drug with a heart attack. And this involved giving these powerful blood thinners when someone was having a heart attack. And these were very effective. However, not everyone responded well to those. And some people actually had serious bleeding. They are still a valid treatment, but we've developed further, more directed treatments that have been found to be even more effective. And this is, as many people would probably be aware, is the main way we treat heart attacks now with catheter-based treatments. On the left side is a picture of a cardiac catheterization lab, which looks like an operating room with a lot of X-ray equipment. And this involves actually going in to open up blocked arteries. The diagram on the in the middle shows a catheter going up from the blood vessel in the leg up to the heart. And on the far right, you can see a catheter that's being introduced into one of the coronary arteries. We also, currently, most procedures are done from the wrist, which is actually lower risk for bleeding and better tolerated. And the main treatment for blockages or in the arteries of the heart now predominantly involve stenting, though there are other catheter-based treatments that we would do. But for a heart attack, the gold standard currently is stenting. So on the left, you can see in the square is a blockage in one of the blood vessels running on the surface of the heart. In the first segment on the left, you can see a stent mounted on a catheter on a balloon. We inflate the balloon that dilates and expands the stent. And then we deflate the balloon and take the balloon and catheter out, and the stent remains. And that has been a dramatic improvement in our way of fixing blockages. And in this picture, I hope this will show well, is a picture of a catheter in the artery of heart, that same place. And you can, you can see that there's I'll run it one more time. that there is a wire down an artery, but there's very little blood flow going down there. What we can often do through the catheter is use special catheters to remove clot. And here's an example of the sort of clot that can be removed from an artery in someone who's having a heart attack. The plot on the left, it looks like a cast of the blood vessel, and you can actually see branch points. And then the second one is additional clot that was removed. And so after that, we can see now that the blood vessel is open, but there's still a lot of narrowing and disease in the artery. And that's where the stent will come in. And if you may be able to appreciate in this picture that same stent is mounted on a balloon, but not yet expanded. And the following picture is what it looks like after it's been expanded. So these are, again, our X-ray pictures of the arteries of the heart done during a catheterization to show how we can fix blockages. And this has been shown to help limit the damage to the heart. In fact, if we can open the blood vessels soon enough, we can actually prevent any heart damage at all. Helps prevent heart damage and heart weakness, and certainly is a very dramatic treatment in improving symptoms. It's having done this for 15 years, it's one of the more dramatic things in medicine where someone is having severe symptoms from a heart attack, and we open up the artery and suddenly they feel dramatically better. This next slide shows, highlights the importance of time in fixing blockage in someone who has a heart attack. We know that the sooner we can get a blocked artery open, the better patients do. And so now every hospital and every community and health system here in the United States has fairly elaborate systems to get patients to the hospital where these treatments are available. And then within each hospital, there's constant work being done to help them speed up the treatment and get the blood vessels open sooner rather than later. In fact, we've been very successful as a healthcare system on the whole here in the United States at helping with this process on the right. Once patients are actually in the medical system, things typically go fairly smoothly. The thing that we're working on now is on the left-hand side of this diagram, which is getting the patients to get into the system when they're having problems. And part of this is recognizing the symptoms of a heart attack and then taking action to get help immediately. And this would be, of course, recognizing symptoms of heart attack, which would be typically chest pain, dramatic shortness of breath, sometimes pain involving the arms or neck or back. And I think we spend a lot of time trying to communicate to patients that if you think you're having a heart attack, the answer is to call 911 immediately to get help. And then because we know that once patients get into the system, they tend to do very well. The problem is some people decide they're going to go to sleep and see how things turn out in the morning. And a lot of times things aren't so good in the morning. So really a lot of our focus now is trying to educate patients and community members about how to recognize heart attack and take that action of calling 911. And here's, to summarize this is, if there's any question about you or a family member having heart attack symptoms, that you want to call 911 right away to access all of the treatments that we've developed. So that's sort of an acute problem that the treatment has evolved dramatically over the last even 70 years, certainly, and even in the last 20 years further. Another condition that we are, that there's been a lot of evolution is treatment of heart valve disease. Again, this is, and I'm going to use that aortic stenosis that I had mentioned before as a typical example. So this is where the aortic valve in the heart doesn't open properly to let blood out of the heart. And so the heart has to work a lot harder to pump the blood, and that can cause severe symptoms. And if it gets bad enough, can actually be life-threatening. The standard treatment for that is to take out the bad valve and put a new valve in. And the historical standard for that is open heart surgery, where the patient is put on a bypass pump to do the work of the heart, and the surgeon will go in and through an incision on the chest, remove the valve and sew in a valve. And there's several different types of heart valves, a mechanical valve and a tissue valve. And these have varying advantages. And overall, in most patients or many patients, this is a very low risk surgery with an excellent outcome that we have decades of experience to prove that it works. However, one problem with heart valve conditions like aortic stenosis is that there's some patients, because of age or other medical problems, are not ideal or felt to be higher risk for standard open heart surgery. And this led to the development of one of the major ways that we treat aortic stenosis now is percutaneously, which refers to, not through an incision on the chest, but by delivering a new valve up through a blood vessel to the heart. And this is for aortic valve, the procedure is called TAVR, or transcutaneous aortic valve replacement. And so we can see that we can deliver a new heart valve, deploy it with a balloon again, and then the new heart valve remains and the balloon is taken out, and that can be fixed. Finally, as we are getting better at treating acute heart problems like heart attacks and heart valve problems, we have many more patients that live many years with heart problems. And one of the things we are seeing increased incidence of and prevalence of is heart failure. Sometimes this is the long-term consequence of other heart problems where the heart is not able to pump adequately. And that can lead to the congestive heart failure that I was discussing before. So how do we treat heart failure? There's multiple approaches to doing that. And of course, if there's some reversible cause of heart failure, we want to treat that. There's multiple medications that have been shown to help heart weakness, and that can actually prevent the heart from getting weaker. In some cases, actually get the heart stronger, help prevent hospitalization or death. Medications are a cornerstone for treating heart failure. There's device therapy, specifically types of pacemakers that are used to help with various aspects of heart failure. Of course, there's lifestyle modification, weight loss, exercise, cardiac rehab are also part of the treatment. And for advanced heart failure, there's treatments, what are called LVAD, which is a left ventricular assist device. These are actually devices that help take over the pumping action of the heart. And of course, for many years, there's been transplantation for end-stage heart disease. So the problem with heart transplantation is the shortage of donor organs. So as far as heart failure is concerned, there's been an evolution over the last 30 to 40 years in our treatment of heart weakness. Medications were very limited for many years, but over the last several decades, we've recognized that there are at least 4 classes of medicines that can help with heart failure. In many instances, patients would be started on one and then others would be added if the heart function was getting worse. But we've come to realize over the last several years that patients benefit from being on as many of these medications as possible. So the standard now is actually a 4-drug regimen for heart weakness. And this, I'm not mentioning specific medications, but these are the 4 classes of medicines, what are called beta blockers, ACE inhibitors and related medicines, special type of diuretics, and the SGLT2 inhibitor refers to a type of diabetic medicine that's also been shown to help heart failure. So if you have heart failure, our medical team is working on getting and making sure our patients are on all of these drugs. And so that would be an important question to ask your doctor: should I be on additional medicines for my heart failure than I'm on now? In addition to the heart failure that I've been discussing, heart failure with reduced ejection fraction or weak heart, there's other types of heart failure as well for which new medications have been developed. And I'm just mentioning these in passing. A condition called hypertrophic cardiomyopathy. Within the last several years, there's a whole new class of medicines that have come out that has shown significant promise. Likewise, for a condition called amyloidosis, there's a new type of medication called transthyretin stabilizers that can help. There's devices that we use that can help the heart when it is weak. There's, as I mentioned, one problem with heart weakness is arrhythmias, where patients can have a cardiac arrest. The standard treatment for that is someone has a cardiac arrest and the ambulance is called and the paramedics will come and shock the patient out of the arrhythmia. However, if that doesn't happen in timely fashion, many patients do not do well from that. A defibrillator is a type of pacemaker that's implanted usually in the upper chest with some electrodes going down to the heart that can help if someone had a heart rhythm disorder or cardiac arrest, deliver a shock to save the person's life. There's another type of pacemaker device called a biventricular pacemaker that can actually help the heart pump better in certain circumstances. And so that is an option for many patients. And of course, there's some devices that do both things. And of course, as I mentioned, for severe end-stage heart weakness, there's actually external pumps that are surgically implanted that can help take over the pumping action of the heart. Sometimes we use that to help a patient get by until they might be able to get a heart transplant. But for many cases, when a heart transplant is not an option or not available, it can become the primary therapy. Now, as you can see, the evolution of the treatment is, that I've outlined, we've started with treatment of acute disease, such as a heart attack, and how we get patients through acute heart problems. Then there's the treatment of chronic disease like heart valve disease and heart failure. And of course, that's all very good, but what's more important, or as important, is doing what we can do to help prevent heart problems in the first place. As I was mentioning to Angelica before the talk, I had spent 15 years helping patients with heart attacks in the middle of the night. Now my practice is more focused on, well, how can we prevent that from ever happening in the first place? So prevention of cardiac disease, that I'm going to spend the next 5 to 10 minutes talking about, really falls into a number of facets. One is, of course, treatment of cardiac risk factors, and I'll go through those and some specific tips. Healthy diet is very important, as I'll outline and point out some resources. And of course, things like healthy lifestyle, exercise is a very important thing that's recommended for everyone, and especially for patients at risk for heart problems or with heart problems. So as far as cardiac risk factors, I'm just going to run through some major risk factors, mainly smoking, high blood pressure, high cholesterol, diabetes, and family history are the major risk factors that we try to address. And I'm just going to give just run through some of these risk factors and some suggestions for them. Smoking is a powerful driver of heart disease, and particularly coronary artery disease. It raises the cholesterol, it raises the blood pressure, it turns on the heart's clotting system, it triggers heart attacks. So quitting smoking is a key component to lowering your risk. And so, and it's easy, of course, to say everyone should quit smoking. It is challenging, but there are some specific things that have been shown to help people quit smoking. Most importantly, I think it's important to try to make a plan to stop all at once rather than the indefinite plan to cut down. We suggest that patients pick a quit date and build themselves up to that date, enlist their friends and family. There's many quit smoking programs that can help. There's also multiple medications that have been shown to be effective in helping you to quit smoking. So it's certainly something to talk to your doctor about. But it starts with, first of all, the idea, if you're a smoker, realizing you have to quit smoking, and then also saying, I'm going to actually take some action to do it. Of course, we want to treat high blood pressure. Blood pressure is definitely associated with the risk of heart attack and strokes, and we know that lowering the blood pressure lowers the risk. And treating high blood pressure, several ways we do that. There's diet and lifestyle, particularly avoiding salt, exercise, and of course, in many patients, medications. The good news about blood pressure is that there's many proven, inexpensive, well-tolerated medicines that can help with blood pressure. And this is just a reminder of some of the main culprits of high salt that can help cause high blood pressure or hard to control blood pressure. Now, it's hard, would be very important also to talk about lowering cholesterol as far as lowering the risk. Cholesterol is what builds up in the arteries of the heart to cause heart attacks. And it's been clearly shown that if we can lower the cholesterol, we can lower the risk. So first step in that would be to dietary changes. We want to follow a heart healthy diet. So that's not heart healthy on the right there. And but I put that in there to say that one of the main focuses for diet is reduction in total calories, portion control. I think in general, Americans eat too much and too many calories, in addition to the wrong kinds of food. As an example of some of the maybe better choices for diet, on the right, there's fish that's broiled, not deep fried, green leafy vegetables, whole grain rice, and vegetables. So now it's hard for me to give comprehensive advice on diet, but the good news is there's so much information that's readily available. A great resource would be at the American Heart Association website, where there's really all sorts of tips and recipes and tips on how to improve your diet. As far as cholesterol, medication is a key component of lowering the cholesterol, and there's many medicines that have been proven to help not only lower the cholesterol, but prevent a first heart attack, prevent a second heart attack, prevent a stroke, or premature death from heart disease. The mainstay of our medical treatment are medications such as statins, that for many or most patients are very effective and well tolerated. For those that's not enough, there's combination therapy. There's also, within the last several years, there's been a number of new medicines that have come out called PCSK9 inhibitors and other medicines that can dramatically lower the cholesterol. And if you've had side effects from statins, such as muscle problems, these specifically don't cause those muscle problems. So there's so many options available. Of course, we want you to control diabetes. And again, it's similar with diet, weight loss, exercise, medications. Family history is a risk, and sometimes that's challenging to piece together your, how much your family history may contribute. And there are ways of assessing your overall risk. And I'm just in brief, if you go to your doctor, you can ask them to do a 10-year cardiac risk assessment, where we put in your age, cholesterol numbers, blood pressure, and other risk factors, and it will actually give us a 10-year predictor of your cardiac risk. In this generic patient, it's 8.9%. We can also give you an estimation of how much your risk can be lowered with optimal risk factor modification. So it's a very powerful tool to help patients to assess their risk. There's other tests that we can do. There's blood tests such as cardiac C-reactive protein or a coronary calcium score that can give also an assessment of your cardiac risk. Of course, the higher your risk, the more steps we can take to help lower your risk. I think I've covered an awful lot here, and I know this is a very much an overview. And you may say, well, how do I assess my risk or get my care or do the right thing for myself? And I think it really involves your cardiac team. And the cardiac team is just not the cardiologist alone. In fact, most heart-related issues, certainly on the prevention end, your primary care doctor would be a very key component of your cardiac team. Now, and that would include assessing your risk, treating risk factors, and starting therapy for many heart conditions. Certainly the cardiologist has expertise to add in all these areas, and also can help with testing and diagnosis and coordinating further care. And I don't work in isolation. I work as part of a very large team, and I'll often involve the interventional cardiologist in patients who have blockages that need to be fixed, or structural heart problems or devices. There's the electrophysiologist who handles heart rhythm problems. There's a heart failure specialist within cardiology to deal with heart weakness. Of course, there's the cardiac surgeons, the cardiac rehab, there's specialty nurses who run heart failure programs, cholesterol and diet. And of course, there's your family and community that also are very important members of your heart team. And I would just say in conclusion, I would say invite you to join the cardiac team, both for yourself and your family members in your community. Some suggestions I might have is, first of all, lead by example. Quitting smoking, leading a healthy lifestyle, facilitating healthy meals with family members, very important to demonstrate heart healthy living. certainly to know the warning signs of heart problems, particularly angina and cardiac arrest or heart attack, chest pains, severe shortness of breath, things like that. Could this be a heart attack? Well, we all can be early warning beacons for our family members and community. And if there's some concern that someone is having an acute heart problem, calling 911 and getting the formal medical system involved. Of course, there's specific things people can do to be part of the heart team, learn CPR. We witnessed with the Buffalo Bills football player who had a cardiac arrest on the field. He was saved by the people around him. His fate was determined before he got to the hospital. So, and it's so critical that, as I was saying before, what happens in the community before you get to the hospital. And again, 2 steps to save a life: call 911 and push hard and fast. So thank you very much for your attention, and I'll turn it back to Angela, and we'll see if there's any questions that I can answer.
Thank you, Dr. Dillon. That was quite the overview, and we do have lots of questions. I first wanted to ask the question about heart attack, and specifically there, has been, talk that women experience heart attack differently than men. Can you talk a little bit about the symptoms a woman might experience compared to what a man might experience?
Sure, I would say that's a very good question. I think that comes up a lot. In general, heart attack symptoms or angina from the heart is usually some sort of discomfort in the chest. It's usually not a sharp pain. It tends to be a heavy or aching. Some people might say burning, and it may go to the jaw or the arms or elsewhere. Now, and that's the most common, and it's also the most common symptom in women. Most women who have heart attacks have some sort of discomfort in the chest. It is recognized that some women and some men too don't have the classic chest pain symptoms. Sometimes it can be severe shortness of breath. Sometimes it can be a vaguer pain in the arms or legs. A lot of times that might be accompanied by other symptoms such as feeling clammy and sweaty all over. Or a severe sense that something is not right. So women are described as having more likely to have not textbook symptoms, but most women have some sort of chest discomfort. So I think I wouldn't say it doesn't break down quite that. We're more the same than different. But and there are other categories of patients that don't have the classic chest pains. For example, diabetics are notorious for having not typical symptoms. Just as diabetics, as many people know, can get numbness in their feet and toes from the effects of diabetes, the same sort of condition can affect the nerves that sense pain from the heart. So again, diabetics would be sometimes don't have the classic chest pain. They may have shortness of breath or severe weakness or something.
Well, thank you. So we have an attendee here who has had 2 stents put in, and they're just curious as to how long stents have been shown to last.
That's a very good question that comes up all line. The good news is stents are, for the overwhelming majority of people, are a permanent fix for that particular blockage. So the stents, I usually tell my patient that comes up a lot, that question, I usually say stents last one lifetime. So now when we put a stent in, sometimes the blockage can come back. Usually if it does come back, it comes back in the first year or so after the stent was put in. Since the evolution of what are called drug-eluting stents, these are stents that have a special drug coating on them, that has really dramatically reduced the number of blockages that come back within the stents. So for most people, it's a permanent fix. Now, when you have a stent, you generally recommend that you have to be on certain medicines, particularly aspirin afterwards for lifetime. And of course, the stent only fixes the blockage, one particular place where the blockage was. And so what it doesn't prevent is any blockage from developing someplace else. So, if someone had a stent put in and now is having chest pain 5 years later, the concern more likely is that it's a new blockage. And that's why, of course, in addition to just fixing the blockages with stents, it's very important that we're doing everything we can do to help prevent more blockages, further buildup of cholesterol elsewhere. So.
So we have, a couple of people who have family history of heart attacks, strokes before the age of 65. When should they be seeing a cardiologist? How do they approach their primary care physician when they want to get a referral?
That's a very good question. And I think the family history is something that comes up a lot. Mother, father, brother, sister who's had a heart attack at a relatively young age. And as you said, less than 65 would be considered premature. And that's as opposed to a grandmother who had a heart attack in her late 80s, how the risk for that might not be as much. And it's somewhat challenging. There's no one gene that mediates the family history. There's maybe dozens and dozens of inherited factors that may do that. So the first step with a positive family history is to talk to your doctor about what are my risk factors other than the family history, because sometimes that's how the family history manifests itself. That everyone in the family has very high cholesterol. There's some inherited forms of high cholesterol. And so if the grandmother has a cholesterol of 400 and the son and the daughter, that's passed down, that would be the main intervention, would be to treat the inherited form of high cholesterol. There's likely many other factors so that would be the starting point. So if you're worried about your family history, you start with the things we know are risks that can be fixed. So if you're a smoker, we want you to quit smoking. If your cholesterol is high, we want to treat that. If your blood pressure is high, we want to treat that. If you have diabetes, we want to make sure the sugars are well controlled. So I think that's the starting point. The other point would be to have your doctor assess your 10-year risk and make sure that we have these, as I showed in the slideshow, these 10-year risk calculators. Now, the 10-year risk calculator does not account for family history. So sometimes that can be an X factor where some additional screening might be needed. So your family doctor or primary care doctor may be very comfortable with doing this. Many are. And there are some specific, but if in addition, they could ask you, send you to a cardiologist. So that'd be something that you could call up a cardiologist and say, I'd like to talk to a cardiologist about my risk. And we don't generally require a referral unless your insurance does. So that would be a valid thing. Now, probably a very useful test, just as far as that might help us sort out whether, if your 10-year risk is very low, that's good. If it's very high, of course, we're going to treat that regardless of family history. If we're sort of on the fence, there are some additional tests that can assess your personal risk. And one of probably the most useful assessment of risk that would, of course, incorporate family history is what's called a coronary calcium score. This is a special type of low-level CAT scan where we look for calcium in the arteries of the heart. And where there's calcium, there's cholesterol. And if your calcium score is very low, that would be consistent with low risk. If you had a high calcium score, then we'd be, of course, more aggressive about treating. So I think that I would say talk with your doctor that knows you and knows your risk factors. And certainly it's something that any cardiologist would be happy to talk to you about. And it comes up, I see several patients, a week with that specific question.
So we talked about how the medical world has changed, and a lot of things in the world have changed as well. Vaping versus smoking. Is vaping as bad as smoking in regard to heart health?
Yeah, that's a challenging question. It's not a substitute for quitting smoking, and vaping may have its own specific health problems, separate from cigarettes. Certainly, cigarette smoking is bad. We've established that, and just in so many ways, between the nicotine and the multiple other chemicals that are in tobacco. But there's other concerns that have been. So, I would not recommend vaping as a method to quit smoking. I just find I don't think it works. The other concern is is that vaping may have other risks. First of all, the doses of the nicotine and other things that are being inhaled are highly variable. The temperatures with which the polyethylene glycol are being vaporized is very variable, and there's the concern that at some of the very high temperatures in vaping can actually cause damage to the lungs and other problems. So I would not consider that a substitute. There are many effective ways of quitting smoking, and your doctor or other medical specialists can be very helpful in helping you quit smoking if you want to quit smoking, which I would strongly advocate for, and do spend a lot of time with my patients who are smokers to really not just tell them to quit smoking, but let them know there's specific things they can do that have been shown to work. And the good news about quitting smoking is, like, unlike some other things, your risk of having a heart attack starts going down within the first few days of quitting smoking. The effect is almost immediately, that the risk starts going down. So it does, ultimately, you can catch up as far as cardiac risk to a non-smoker after a number of years by quitting smoking. But really, you have to quit smoking altogether. So.
Aspirin has come up a few times. Is daily aspirin still a treatment option for people? And if somebody is experiencing signs of a heart attack or stroke, should they take an aspirin as they're seeking medical care?
That's a very good question, and that has come up. Now, I should say is that the press and the sort of public awareness about aspirin has changed a lot, but the medical recommendations really haven't changed that much. In that there's never been a clear recommendation that every person over a certain age, say, should take aspirin. Aspirin has been shown to help prevent heart attacks, but it also has risk of bleeding and other side effects. So I think that it's not recommended that everyone take aspirin as a matter of course, once you reach some specific age. Now, there's clearly a benefit for aspirin in patients with established heart disease. So if you've had a heart attack, if you have coronary disease, if you've had a stent, if you've had a stroke, aspirin is one of the key medications. I would say, as far as taking aspirin, if you think you're having a heart attack, I think if you think you're having a heart attack, the answer is to call 911 and you'll be instructed on what to do. So I wouldn't say the answer is, if you think you're having a heart attack, run to the cabinet and take aspirin. The answer is to call 911 and then we'll take it from there.
Right. And could you talk a little bit about the signs of a stroke? I know I've seen some of that recently. A newscaster recently had a stroke on air, and so that's what you.
Thank you for whoever asked that question. Now, because a lot of what I said about heart attacks and strokes, or heart attacks and blockages in the arteries of the heart, would apply to stroke, as far as the urgency about needing treatment. And again, our treatment of stroke has evolved dramatically over the last 10 years, in that if we can treat someone who's having a stroke in the early stages, we can help prevent a stroke from happening or limit the damage to a stroke. So so I would say, again, I would reiterate that if you think that you're having a stroke, the answer is to call 911 and get to someplace that treats strokes quickly. The warning signs of a stroke, and I just I had left it out, but I'm glad that we're talking about this, because I think it's very important for people to be aware of that. Typical would be, and a lot of times symptoms of strokes are something that family members notice. The person having the stroke might not notice it. So, but certainly weakness or numbness on one side of the body would be a very classic symptom of stroke. So if your whole right side of the body is numb, or you're having trouble moving one side of your body, or one hand is inexplicably clumsy, that could be a sign of a stroke. Difficulty speaking, trouble finding words to say, or slurred speech, that's something that often family members will notice, that family members not speaking properly, their speech is garbled, or they can't say the words they want to say. And sometimes a person having stroke might not notice that. So that's very important. And the other is a droop or asymmetrical face. So one side of the face drooping. So if a person can't smile, if only, if when they go to smile or only one side of their face is moving. So one side of the face is drooping. So that would be a classic sign. So again, facial droop, difficulty speaking, numbness or weakening on one side of the body. So visual, I should also say visual disturbance as well. Loss of vision in one eye or the other, or significant change in vision. So
Thank you. Can we talk a little bit about maintenance? So if somebody has had heart issues, has had a heart attack, or has had coronary artery disease, is that reversible through their lifestyle changes, or is that something they will always have to be wary of?
Yes and yes. It is absolutely. It can be, reversed or mitigated, but it's something that is always there. So coronary, again, I go back to the analogy about fixing the blockage. So if someone has a blockage from cholesterol that they're having a heart attack, and we open that up and put a stent in, that has fixed that problem. But the coronary artery disease or the buildup of cholesterol in arteries happens in all throughout the arteries of the heart, and it happens all throughout the body. So it's a predisposition or process that's always there and ongoing. So if someone's had a heart attack, certainly they need follow-up to make sure that whatever treatment for that heart attack is, there's no late problems from that. But also we want to make sure that we're doing everything to help prevent cholesterol buildup. And clearly we know from clinical trials that we've seen that if we can get the bad cholesterol down very low, we can actually see regression of cholesterol plaques in the arteries of the heart. And this is also demonstrated in animal models as well, that if we give animals a diet that cause buildup of cholesterol, and then we can give cholesterol medicine that can reverse it. So, but you don't have to have regression to benefit. Mainly we want to prevent progression, things getting worse. So the outlook for patients having a heart attack is, in many cases is excellent. But if you do have lasting damage or multiple blockages, there's much that we can do. So it's sort of an ongoing, relationship that you're going to have with your doctor and cardiologist for ongoing monitoring. I used to, maybe it's an oversimplification, but many years ago, patients would have open heart surgery for blockages. And, when they left the hospital, we were, get a handshake and say, well, if you have problems, we'll do another heart surgery. But now there's so much that we can do to help prevent that from happening. So I think that there is there's so much that can be done and can help. So we want to make sure that you're not lost to follow up with your heart team.
Thank you. So we have someone, this is kind of a particular question, that recently had a CT scan of their coronary arteries and got a score of 587, which I don't know if that's high or low. But they're wondering if they should have a stress test and make an appointment with a cardiologist based on that.
Well, I want to just be careful here that this is not probably the forum for, me to give specific advice on that. And of course, there's some differences in the scales of coronary. It sounds like the questioner is referring to a coronary calcium score. If your calcium score is elevated, certainly that suggests you have some cholesterol buildup, and that we want to be aggressive about lowering it. It doesn't necessarily mean you have blockages. If your calcium score is high enough, that could be concerning for blockages, but not everyone who has coronary calcium necessarily needs a stress test or to go in and fix the blockage. That's, I think, a common misconception that we're going to go and take someone with no symptoms and put a stent in a blockage that's going to prevent a heart attack. There's very little evidence that strategy works. What works is treating the risk factors and the cholesterol and quitting smoking and these other things that we've talked about. But I would say to that person, you definitely would want to talk to your doctor in detail about that, and certainly bring in a cardiologist or other specialists to say, well, what next?
Right. Yeah. And we have a question about another test. Does Dartmouth Health offer CAC tests? I assume that we would.
I think if that's coronary artery calcification test, I presume that's what it is. Yeah, that's
Okay.
just another term for
Okay.
the coronary calcium score test. Yes, this is a low level CT scan, X-ray scan where of the chest, where we look for calcium in the arteries of the heart, and then we compile a score of how much calcium there is equivalent to how much cholesterol there is, and also with the risk. So if you have a low calcium score, it is usually associated with low risk, high calcium score, high risk, and that can help guide us. So Dartmouth Hitchcock Medical Center does do coronary calcium scoring. And one thing people should know about that, it's for unclear reasons to me, it's not typically covered by insurance. So it's usually an out-of-pocket expense, several $100s. I know Dartmouth, as most hospitals, they try to keep that as low as possible to make it feasible for people. But that is always something you have to be aware of. But it's certainly, there's not a I should just say there's not a recommendation that everyone gets a coronary calcium score, but it definitely is a very useful test if we're on the fence about your risk, or we think that there's other factors that we might want further risk assessment.
Okay. I think that we have answered questions that are not specific. If you didn't get your question answered, it might have been a little too specific, and I'm sure Dr. Dillon would recommend that you talk with your provider, your primary care provider. And if your insurance doesn't require it, you can call a cardiologist about maybe getting in for an appointment. But I think at this point, we have answered most of the questions. So I want to thank you, Dr. Dillon, for being with us this evening. Again, I would like to let you know that this whole presentation will be available on our website in a couple of days, and that'll be available at go.d-h.org/HLS. Dr. Dillon is at our Dartmouth Hitchcock Clinic in Concord. And we do have cardiologists in all of our clinical locations in the southern region, so Nashua and Manchester as well. And we are grateful for your time this evening. Thank you so much for registering and for coming out. Please don't forget, we have that survey at the end of this event. It should pop right open for you. So if you could take that survey, if you have additional questions, you can also put that right in the survey, and I will do my best to get those answered for you. We'll send your information along. So with that, Dr. Dillon, do you have any final words?
Well, I just want to say thank you for everyone who expressing interest in this. I think this is, for me, this is what I do every day. And so it's great to talk to people and answer their questions. I enjoy it very much. I hope you found it helpful. Certainly, if it's provoked any questions or concerns, or certainly you could put that in the feedback. And of course, if you have specific medical questions about your specific situation, you definitely want to talk to your doctor about that. So.
Absolutely. Well, thank you so much, everyone, and have a great night. And hopefully we'll see you next time.
All right, take care now.